very afraid, and that he had no idea what in the world he had done. He was the kind of person that always was thinking, you know, I want to make sure I do my part and do what I should do. And when he thinks, I think he thought he was in trouble. And what in the world was it that he had done, and what could he do to fix it? But he didn't have the mental capacity to figure it out. And they didn't know what to do.
And what did you do when you stepped off the elevator and saw
I
this?
just stepped off the elevator, and I get down on my knees, because I had figured out that my dad's field of vision wasn't as wide as it used to be, so that I knew I had to get right down and look at him, not too close, in the face. And I just said, "Dad, would you like a cup of coffee?" And he just looked at me and he said, "Oh, yes." And then we got up and walked down the hall and had a cup of coffee, and it was over. Wow. That quickly. So there are things that can be done. And in my experience caring for my dad, more often than not, it's either some basic need that he had as a person, or something happened in his environment that he couldn't figure out, and it made him afraid. So fear was a huge motivator for his behavior sometimes.
Well, and I think that the little trick you just said about being sure that he could see who he was engaging with. I mean, if he was sitting there with 4 or 5
they were standing over him, and he knew they were there, and he knew, but he couldn't compute on, they were way up there looking over him. Actually, that's a position that would make a lot of people afraid.
Even without
the dementia.
Yeah. Wow.
And I think this also illustrates a way that families can work with caregivers in facilities. You know, Emily shared with the caregivers at that facility the types of things that agitate her dad and scare her dad, but also things that can calm her dad. And in facilities that really take a special interest in caring for patients with dementia, the staff, either just by their natural interest and personality, understand people with dementia, or they're trained to work with patients with dementia. They look at them as individuals and try to find out as an individual person, what are the things that comfort them. And I know Love is very experienced and very good at these techniques.
Definitely.
Do you want to share?
Well, you talk to the family. You find out what they like and what they don't like. Some people don't want to get woke up early in the morning. Who wants their breakfast at 7 o'clock every single morning? Right. Some people like coffee. They like long walks. They like gardening. You have to find out because the facility that the patient is in and the family, and the doctors, everybody has to work together to help that patient.
Right.
So finding out their likes and dislikes, I think plays a big role in taking care of the patient.
And do you think that the family members are expecting, I mean, it seems in our society, we see so many drug advertisements on the TV that I think we may have an expectation that there's a magic pill for everything. And I just wonder if you could comment on that, and you say you have to work with the families, but if the families feel like there's a magic pill, but I guess there isn't one. Is that true?
I don't believe so, Claire. I haven't found it yet. A lot of families do hope that there's a magic pill to solve whatever problem. And I think about if I were an individual in a nursing home, and let's just pretend that there was a magic pill that you could give me that had no side effects, no risks, and was cheap, and I was given that medication so that my behavior would meet the expectations of my caregivers. You see where I'm going with this?
I'm sensing you're something of a rebel and you would not want to be sedated.
No, I would not want to be given these medications. You know, and these medications do have risks and do have side effects, and they have a cost associated with them.
I want to interrupt you because I want to kind of go through more of those side effects one by one, so that I think they're very serious, and I don't think consumers know about them. And Emily, I'm going to ask you in a minute to weigh in what you knew and when you knew it, if you gave permission for your dad to receive these drugs. Let's talk about, you said that very serious side effects, including an increased risk of death.
That's right. Some studies have shown that there's an increased risk of death using these medications in elderly patients with dementia. And those causes of death are typically cardiovascular events like heart attacks and strokes, but also infections.
Wow. Well, I would think significantly increasing a risk of death, that is a not good side effect.
And when we prescribe medications for patients, we're supposed to receive informed consent from either the patient or the family member. And what that means is having had a discussion with the family about the potential risks, benefits, side effects of that medication, and making sure that the family understands those risks and wants to go ahead and accept that medication for their loved one.
And you probably also have to explain what the alternative is, so they have a true choice, right?
That's right. And what we find is oftentimes people are started on these medications without any form of informed consent. Often the families have no idea that this medication has been started on their loved one. Some other common side effects.
How can that happen? That doesn't sound legal.
Uh,
Okay. Not to put you on the spot, but so family members, beware. You actually could experience a situation, and not just in a nursing home, other care settings, where your loved one is put on an antipsychotic, but you have not had the discussion to give informed consent. Is that what I'm hearing?
It certainly happened with my dad.
What happened, Emily? Tell us.
We were only told it would make things mellow, make him more peaceful, make, all what they wanted us to hear, I suppose.
Did they tell you about these risks?
They did not tell us anything about risks. They did not say black box or even mention it. They did not tell us things to look for, the negative things to look for, and they did not tell us what might happen to his affect if he went on this medication. And even when we came back and asked about it, they tried to brush all that aside. I think in the industry of caring for elders, these drugs are so standard in use that that's what you do.
People don't give it a second thought, I guess.
No, and we had to find out ourselves. We had to figure out about the drugs and what it was doing to my dad, and then we had to fight the industry, which is tough.
Yeah, and I think that so that the viewers know kind of the scope of this problem, so they don't think we're sort of exaggerating something that happens occasionally. In Virginia, more than 22% of nursing home residents are on an antipsychotic, and these are residents who don't have schizophrenia or Tourette's or Huntington's. They don't have the severe mental illnesses that actually the drugs are approved for. So if you think about 22.08%, that's more than 1 in 5. That's for the 37,000 or whatever nursing home residents in Virginia. I mean, that's thousands and thousands of human beings who are on these drugs right now.
Especially, Claire, if you think about, if somebody asked you, Claire, would you like to take a medication that increases your risk of death and increases your risk of confusion and sleepiness, impairs your ability to walk, increases your risk of falling, and several other side effects? How would you like to take that medication?
I would not like to take that medication at all, and I would certainly, if I have dementia and I can't speak for myself and I'm relying on someone like a family member like Emily to care for me and make decisions for me because I can't speak for myself, I certainly want her to get the facts, to ask the right questions, to learn the side effects, to to protect me? Because it sounds like the system that we have going right now is not going to protect me from this.
And if you want your loved one to be off those medications, if they already are, it is really hard to accomplish that goal if you don't have the right place.
So tell me, it sounds like you tried to get your dad, the caregivers, to take your dad off of the drugs?
We
tell us that story. What happened?
We told the institution where he was that we wanted him off these medications, and they did not like that idea. What they ended up doing, and I'll try to tell this story quickly, but it is really an important, it'll give you some really big things to think about. They took him off cold turkey, which is, you have to be very careful if you take people off these drugs that you step it down gradually.
Is that right? And you need to do a gradual dose reduction kind of a...
Well, it depends too. If somebody was started on an antipsychotic in the hospital for an acute episode of agitation and they were given it as needed, you know, often we'll just stop that completely because they haven't been on it for a long time. But when patients have been on these medications for a long time and they come to our facility, what we'll do is talk to the family, try to find out if there is a history of serious mental illness that we're not aware of, and talk with the family, explain what we would like to do, explain the risks of these medications, and if everybody's in agreement, we'll try reducing these medications over time, but we don't do it suddenly. We try to gradually reduce the dose over time.
Well, but for your dad, they just cold turkey?
It didn't happen that way, and he, over a week's worth of time, his behavior became more and more agitated, and they didn't even tell us they had taken him off these drugs. We didn't know what was happening. We had no explanation for the way he was behaving.
So what was going on? What was he doing?
He was very agitated. He would yell out. He'd walk around. He couldn't sleep. Things upset him much more. And one evening, they apparently couldn't deal with him, so they said he had to go to the hospital. And that was simply because they couldn't deal with him. They were getting rid of him. And they called the rescue squad. They called the police. They tied my dad down in the rescue squad on the gurney. And of course, the police lights are going round and round. And here's my God-fearing, you know, law-abiding dad. He must have been terrified out of his mind. They did
Now,
not,
were you with him while this was
no,
happening?
they did not call us. And so they called us finally when he was at the emergency room. And of course, I quickly went. And this was in the middle of the night by this time because it had been going on. And I went there, and finally the physician that we saw said, well, he's in withdrawal. And I said, you're kidding. So they determined that they needed to put him back on, but what they wanted to do was send him to the psychiatric unit at this institution. And I couldn't, in all my wildest imaginations, think that this was a good idea, because I'm thinking, well, they're just going to say he ought to be on these things all over again. What we need to do is figure out some way to take him off these things safely. So we refused to allow him to be admitted to the psychiatric floor, and I called the institution because I was bringing him back, and I was going to be with him. I would stay with him, and it was early morning, and the person on the phone said to me, well, we understand that unless he goes to that psychiatric unit for a 2-week evaluation, he is not to come back here. He will not be allowed to come back here. And I just said, you know what? He's coming back. I'm not that far away. And I took him back in there. Now, they did not refuse to take him back, but they were hanging this over my head. If you don't do what we want you to, then this is what's going to happen.
So you're a pretty unusual advocate. If you
it's hard. It is very, very hard to resist an entire institution and people who have more medical education than you do.
Did you have, by this point, a doctor or someone who was helping support you to advocate for your dad, or were you just doing what you felt was right?
We had switched a doctor because we had, but at that point, we decided we haven't got the right doctor. So we then found a physician who matched more what we wanted. And that is really critical for family members, to find a physician who will work with you.
Okay. So you're telling viewers that there's going to be a lot of pressure, I'm
There will
taking,
be
if
a
you
lot.
question the recommendation that your loved one really has to be put on antipsychotic drugs, they're going to really not take your meddling very well.
That is correct.
Okay. And you were able to do that, it sounds like, pretty much on your own or just with your support of your family. But I think probably most people are not going to want to do that by themselves. It sounds very scary.
It's very tough, and it's very scary, especially in families where this disease has exacerbated maybe some issues that people have with each other. If a family can work together and come together and have the same idea in mind as to what can happen, even then it's tough. But if you don't agree, that becomes even more difficult.
Well, I would like to be sure that our audience members know that nursing homes have organizations called family councils. Not everyone has an independent or a strong family council, but if your nursing home doesn't have a family council, you should start one. You should find other family members who are interested in working together to support each other and to learn information and share from your experiences, because you don't want to be out there alone when you're advocating against a system that may be trying to use antipsychotics, not because it's what's best for the patient always. They might be doing it for their own convenience, to get residents to sit down and be quiet and be sedated. They might be doing it, I would speculate, because of staffing. You know, there are pressures on nursing homes, and maybe they don't have enough staff or well-trained and supervised enough staff to handle these really, really difficult cases. I mean, have you got any comment on that, Love?
Well, I've worked in different areas, and sometimes in certain facilities, the goal is to have everybody on antipsychotic. And me coming from a facility where we don't use them at all, I'm like, these patients shouldn't be on these meds. I mean, what is going on? And you know, so it's.
That's such a really important point. And when you're thinking about, like, if you're trying to decide what facility might be right for your loved one, if you need to rely on long-term care, this is a critical area to ask questions, because it's not who the patients are in a nursing home that determines how much antipsychotics are used. It's not like, oh, we use a lot of antipsychotics because we have very, very many people who need them. It's more the philosophy of care, isn't it? Can you comment on that?
Yeah, I would completely agree with that, Claire. It's interesting, even within our city, there are, you know, several different facilities, maybe 6 or 7 different facilities. In each facility has its own personality and its own culture. And part of it is, like